I think there's a lot of information about trying to collate the different modalities, so how we sort of have a hierarchy of imaging when we choose which modality, say for mitral regurgitation. We just had a session this morning and talking about making sure you use 3D when it's available, using quantitation for mitral regurgitation, when to use MRI, both for quantitation and also looking at sort of remodeling. So looking at the hierarchy of which modalities to use and how we integrate those for making decisions for the patients. I think it starts with the patient, always, how they're feeling. And if there's a question that, say for example, what their disease is, if it's valvular disease or heart failure, how symptomatic they are, you might do a stress test, so you might employ that. If we're trying to make decisions about surgery, what type of surgery, or is it a trigger for surgery, then you want to be very sure that you have good data. And it's okay, we want to be cost effective, but we certainly want to be clear, is it really significant regurgitation or stenosis, and is it symptomatic? So employing sort of the most tried and true methods and making sure that data is reliable. And then doing confirmatory testing if you need it, whether it's MR, CT, catheterization. So I think that's sort of the hierarchy of following patients. No, I don't think so. I think it's, that's sort of the day-to-day work that we do, is you see patients most of the day, and then you have to take that information of what they're feeling and get some objective data as well, so that you can integrate that and help them make the decision that's best for them about medical management, some of the new percutaneous methods for treating valves. Makes us feel like it's easier or better, but I think we still need to use that same rigorous method of decision making. There's some interesting data that people assume new technology is always better, and without rigorous testing, sometimes people get ahead of new technology. And so I think meetings like this, and our ACC meeting every year, and the AHA meeting, where you have presentation of clear scientific data and you have a chance to review that in context of what's come before by some leading experts, is really crucial. So it helps us all sort of put that in context. We want to be cost effective, obviously, because we're all aware of that, but we also have a primary obligation to our patients. So we want to do what's best for them and have their consideration. So when new technology comes out, I think looking at the body of evidence, listening to what some of the experts feel, how that fits into the new ways, and making sure that your local expertise matches that. And I think that's another translational piece that's important, whether it's the new imaging or the new surgeon or the new interventionalist. You want to know what your local expertise is too, so you can apply it.